Hello and welcome everyone. I'm Dr. Joanne Clovis and I'm part of a research team in the Faculty of Dentistry at Dalhousie University. In this video, we will demonstrate a survey protocol that we used to collect data on over 1,100 people during the TOHAP study, a survey of the oral health of adults aged 45 years and older in Nova Scotia. The survey involved both an interview and an intraoral examination, and it included people living independently in the community as well as those in long-term care. These assessments were conducted in dental clinics wherever possible, or using a portable chair and light in long-term care facilities, public health clinics, or even small local hospitals. We'll begin with research assistant Evelyn Bennett giving a demonstration of the greeting and confirming the consent to participate in both the interview and the intraoral examination. She'll then conduct a shortened version of the interview. After the interview, Dr. Deborah Matthews will demonstrate the intraoral examination. Let's begin now with the interview. The TOHAP interview was developed using questions from the Canadian Health Measures Survey, the Oral Health Impact Profile, and our own pilot study. The interview includes questions on sociodemographics, such as gender, age, and education, self-perception of oral and general health and chronic health conditions, medication use, sun exposure, smoking history, alcohol consumption, labor force activity, and income. Evelyn Bennett and Mr. David, a volunteer participant, will demonstrate a small sample of the 71 interview questions.
Good afternoon, Mr. David. Thanks for coming in this afternoon and helping us with our study. Can you follow me, please? Take a seat right here. Now, you've read and signed the consent form. Do you have any questions?
No, I think it's pretty straightforward.
The next part of the paperwork we need to complete before you see the dentist is a questionnaire. The questionnaire is strictly confidential. Your name doesn't go on the form. And I'll read each question to you, and in most cases, responses for you to choose from. Okay? The first question, what is your current marital status?
Married?
In general, would you say your health is excellent, very good, good, fair, or poor?
Very good.
How often in the past year have you had painful aching in your mouth? Very often, fairly often, occasionally, hardly ever, or never?
Never.
How often in the past year have you found it uncomfortable to eat any foods because of problems with your teeth, mouth, or dentures? Very often, fairly often, occasionally, hardly ever, never?
Never.
How often in the past year have you been embarrassed because of problems with your teeth? Very often, fairly often, occasionally, hardly ever, never?
Never.
How often do you usually brush your teeth or clean your dentures?
I'd say on average probably twice, between 2 to 3 times a day.
How often do you usually see a dental professional? More than once a year for checkups or treatment, about once a year for checkups or treatment, less than once a year for checkups or treatment, only for emergency care?
Probably 3 times a year on a regular basis for checkup or repair.
In the past 12 months, have you avoided having professional treatment for some or all of your dental problems?
Anything like that?
Do you have insurance or a government program that covers all or part of your dental expenses?
No.
Have you ever been diagnosed with diabetes?
Yes.
In the past month, did you take any prescription medications?
Yes.
Thinking about the total income for all household members, From which of the following sources did your household receive any income in the past 12 months? Wages and salaries?
No.
Income from self-employment?
Yes.
Dividends and interest?
No.
Now, that completes the paperwork. Thank you
Okay.
very much. The dentist is ready to see you now,
Okay.
so you can just follow me.
The second part of the TOHAP survey was an intraoral examination. The exam is modeled on that used by Health Canada during the Canadian Health Measures survey. It was modified for use with an older population. It covers the following components in sequence: oral health questions, restrictions to probing questions, dentate status, prosthetic status, removable prosthesis quality, jaw function, mucosal status, orthodontic status, periodontal assessment, tooth status, traumatic injury, and treatment needs. In this video, you will see Dr. Deborah Matthews demonstrate the exam on two different volunteer participants, Mr. David and Mr. George, while research assistant Amani Toma records the data in a program on a laptop computer.
This is Mr. David, and this is Dr. Matthews,
Pleased to meet you.
and Amani.
Have a
We'll be
seat.
doing recording the information on the computer.
Thanks very much for coming to help us out today.
Okay.
We certainly appreciate it. Get a little comfortable there.
The examiner begins the exam by asking the participant a series of questions about their oral health treatment needs and problems they've experienced in the past month.
In the past month, that is a month ago from today, have you had a toothache at all?
No.
Have you had any pain in your teeth when you have hot or cold food or drink in the past month?
Yes, I can,
Yes?
yeah, I've had trouble with cold
With cold?
on teeth, yeah.
Okay. In the past month, have you had severe tooth or mouth pain at night?
No.
Have you had pain in and around your jaw joints in the past month?
No.
Good. In the past month, have you had any other pain in your mouth? No?
No.
Lovely. In the past month, when you brush your teeth, have you had bleeding gums?
No.
Good. In the past month, have you had persistent dry mouth?
No.
No? So you're not waking up at night to have a sip of
No.
water or anything?
No.
All right. In the past month, have you had persistent bad breath? That's always an awkward question to ask.
I don't really know. I don't.
No one's told you.
I don't think so.
All right.
A second series of questions are then asked to find out if the participant has any restrictions to probing of their gums. If they have probing restrictions, the subsequent periodontal assessments will be modified.
Now, just so that we can determine how much of the oral exam we can do, I have a couple more questions.
Sure.
When you have dental treatment, do you have to have antibiotics first?
No.
No. No problems with your heart valves that have been diagnosed?
With my,
Heart valve,
not the heart valve, but I got congestive heart failure.
congestive heart failure, okay. But no congenital defects in your heart, no congenital heart disease that you're aware of?
No,
You've never had bacterial endocarditis?
if I have, nobody's told me.
Well, you would remember, because that's a mouthful. How about rheumatoid arthritis?
No,
Good. No bleeding problems like hemophilia?
no,
No artificial materials in your hearts or veins or arteries?
no,
Any joints that have been replaced in the last 2 years?
No.
Knees or hips? No? And you're not taking any medication that would cause your immune system to be suppressed, or chemotherapy, anything like that?
no. I think the answer to that is no.
All right.
Research assistant Amani Toma records the data in a program on a laptop computer. The next step in the examination is to assess the dentate status and prosthetic status of the participant. The participant is classified as dentate in both arches, dentate upper arch only, dentate lower arch only, edentulous with implants, or edentulous. The prosthetic status of each arch is assessed and classified as no prosthetics, fixed bridge, implant, partial denture, either acrylic or cast chrome, or full denture. If prosthetics are present, the participant is asked how often they wear their denture, whether all, most, or some of the time. And the prosthesis is examined for stability, retention, structural problems, and hygiene.
And your upper denture, do you wear that all of the time, most of the time, some of the time?
Except when I go to bed.
Except when you go to bed. All right, so we'll call that all of the time.
Right.
Now, I'm just going to check a couple of things, and then I'm going to take your denture out.
Okay.
So, I'm going to test the stability first by placing 2 fingers sort of on the clasp rests, and it's stable. And with a complete denture, we would check the retention by having the patient, can you just lick your lips? Good, and just part them. All right, it's retentive, it's not coming out. Now, I'm just going to pop this out, maybe. I'll get you to pop it out. Thank you. Oh yeah, that fits very well. All right, we want to check to see if there are any missing or broken parts. We don't count worn teeth. And we look to see if there is plaque on 50% or more of the denture. The structure is fine and the hygiene is fine. So we would do that for both arches, but he doesn't have anything on the lower.
The next stage of the exam is to assess jaw function. Jaw function is assessed by looking for a restricted jaw opening, occlusal attrition, or inadequate occlusal contacts.
Can you just open as wide as you can for me? All right, so maximum opening is fine. He's got bilaterally, he has more than 2 opposing teeth on the right and the left, and he does not have abnormal wear. So that's all fine.
The participant is then assessed for the presence of a variety of mucosal conditions, including angular cheilitis, white patches, stomatitis, hyperplasia, glossitis, sinus or fistula, ulcers, alveolar atrophy, and ridge fibrosis. Let's look at some pictorial examples of these conditions. Here's an example of angular cheilitis, which is inflammation and fissures at the angles or corners of the mouth. If white patches are present, they are classified as leukoplakia, lichen planus, or candidiasis. Here's an example of leukoplakia. Here's an example of lichen planus. And here is candidiasis. This picture shows an example of denture stomatitis, which is inflammation under the denture. This is an example of denture-induced hyperplasia, or hyperplastic tissue associated with the border of a denture. Glossitis is an inflammation of the tongue. It does not include geographic tongue. A sinus or fistula is an opening on the gum or soft tissue related to an abscess. Aphthous ulcers are ulcers that are transient and painful. Finally, ulcers that are of unknown origin, including traumatic lesions, are classified as a traumatic or unspecified ulcer.
Mucosal status is next, and we're going to look for, starting from the outside in, any angular cheilitis, any white lesions, any ulcers. And just stick your tongue out at me. I'm just going to catch it. Look for glossitis. Lovely. And I'm just going to check the roof of your mouth. And that's all fine. All right, so there are no abnormalities in the mucosa that I can see.
Following the mucosal assessment, participants are asked about previous orthodontic treatment, and any current orthodontic appliances are noted, such as the ones listed here. The next stage of the exam is a series of periodontal assessments, including gingival status, debris and calculus scores, and measurement of attachment loss, and probing depth. First, we assess the severity and presence of gingivitis using the gingival index. The gingival index assesses the level of inflammation present around the teeth. The gingiva of the 1-6, 1-2, 2-4, 3-6, 3-2, and 4-4 are assessed for color, contour, texture, and presence of bleeding after swiping the sulcus with a probe. Each tooth is assigned a score of 0 to 3, where 0 equals no inflammation, 1 equals mild, 2 equals moderate, and 3 equals severe inflammation. There are no substitutions if any of these teeth are missing. Here's an example of a gingival index of 0. There is no inflammation, bleeding, or edema. With a gingival index of 1, there is mild inflammation, a slight change in color or slight edema, but no bleeding after swiping the sulcus with a probe. A gingival index of 2 indicates moderate inflammation with redness, edema, glazing or bleeding after swiping the sulcus with a probe. Finally, a gingival index of 3 indicates severe inflammation with marked redness and edema, ulceration, or tendency to spontaneous bleeding.
You want to swipe the probe around the gingival sulcus. On the facial and the lingual to see if there's any bleeding. You look at the marginal gingiva to see if there's any redness. There's no bleeding and no redness, so this would be a 0 for 1-6. 2-4. Is a 0. 3-4 is 3-6, pardon me, is missing. It's okay, so is 3-4. 3-2. 3-2 is 3-1. Again is a 0. And the 4-6, 4-4, thank you. That's why we have recorded the have a line. Is a 0.
The remaining periodontal assessments include 4 different indices: the debris index, calculus index, attachment loss, and probing depth. In these assessments, index teeth are used to represent each sextant in the mouth, and therefore, unlike the gingival index, substitutions for missing teeth are allowed. The participants' responses to the earlier restriction questions will determine whether or not probing can be done. Let's look at the debris and calculus assessments first. For the debris and calculus indices, the buccal labial surfaces of the maxillary posterior and mandibular anterior sextants are scored, while the lingual surfaces of the mandibular posterior sextants are scored. For the debris index, the tooth is scored on a scale of 0 to 3, where 0 equals no soft debris or stain, and 3 equals more than 2/3 of the surface covered. Debris is defined as soft foreign matter loosely attached to the tooth. The presence of debris is detected by placing the tip of the periodontal probe perpendicular to the tooth surface and dragging it along to see if debris accumulates. The index teeth are also scored on a scale of 0 to 3 for the calculus index, with 0 representing no calculus and 3 indicating that more than 2/3 of the surface is covered with calculus and or there is a heavy band of subgingival calculus.
If we were looking at the second quadrant, there's no debris and no calculus on that 6 on the facial. In the anterior, we do the 1-1. If that is not present, we use the 2-1, and then we go back and forth until we run out of teeth, if they're absent. So again, there's no, oh, I lied. There's less than 1/3, so there's a 1 on the 1-1. So we have some plaque. No calculus. And again, there's no calculus or debris, so that's a 0. The facial of the mandibular anterior sextant. There's a 0. And so I think we have a little bit of plaque here, so that's a 1.
Attachment loss and probing depth are measured using a Williams periodontal probe, which has bands at 1 mm intervals. All measurements are rounded down to the nearest whole number. Probing depth is defined as the distance from the free gingival margin to the bottom of the periodontal pocket. 6 sites around the tooth are assessed, and the highest score is recorded. Attachment loss is defined as the distance from the cemento-enamel junction to the bottom of the sulcus. Again, 6 sites on each index tooth are assessed, and the highest score is recorded.
So we want to just walk that probe around on the facial and the lingual. Going to angle it just slightly interproximally. And then as well on the lingual side, we're going to do the same thing. And we're going to take the deepest probing depth and attachment level. When we do attachment level, we want to estimate where the CEJ is and measure from there to the base of the sulcus. Probing depth will be from the gingival margin to the base of the sulcus. So in this case, we would call that 2, because we can still see the black line for the 3. And he has no recession and no inflammation, so his probing depth and attachment level on that tooth is the same. So it would be 3 for both of them. He has some recession, so we'll just estimate that the CEJ is probably about the level of that margin. So in this case, our attachment level is going to be larger than our probing depth. So while our probing depth is 2, our attachment level is going to be probably 3. From the base of the sulcus to the pregingival margin, and the deepest here is 2. We want to round down, and the attachment level, the deepest is 3. So I would count this as being the gingival margin. So we've got about a 3 for probing depth and 5 for attachment level. We've got a 1 for probing depth and a 5 for, 6 for attachment level. So we have a 2 for probing depth because that 3 is not covered completely, and I would say a 6 for attachment level.
The next stage in the examination is to assign each tooth, excluding the 8s, a tooth status code for both the crown and the root. There are 21 different codes for tooth status that describe whether the tooth is sound, missing, decayed, or filled. Let's look at some examples. If the tooth is missing, the reason it is missing, that is orthodontic, trauma, caries, or unerupted, is determined by asking the participant. Decayed teeth are classified as severely decayed, pit and fissure, smooth surface, or both smooth and pit and fissure caries. If the tooth is filled, the type of filling is specified, including whether the filling is defective. There are also codes for bridge abutments, crowns, and veneers for aesthetic purposes, implants, and trauma-fractured teeth.
So we want to do the crowns and the roots. This is an 8, not a 7, so the 7 is missing. The 6 has amalgam on the crown, sound on the root. The 5 is sound and sound. The 4, sound and sound. The 3, sound and sound. The 2 has amalgam on the crown. The root is sound. The 1 has a resin on the crown. The root is sound. Just going to get you just to turn your head just a little this way. Perfect. We have a resin on the 2-1 crown, and the root is sound. The 2-2, we have what looks like, let me get it over here, some decay. You see quite a halo there, so we're going to assume that that's decay, and the root is sound. The cuspid is sound and sound. The 4 is sound and sound. The 5, 6, and 7 are missing. We have amalgam. No, we have other on the crown, and we have amalgam on the root. So even though this is a full crown, we still call it other. The 6 is missing. The 5 has amalgam on the crown, sound on the root. The 4, sound and sound. The 3, sound and sound. The 2 has a resin, so it's other and sound. Sorry, the 3-1 is missing, the 4-1 is missing, the 4-2 is missing, the 4-3 is sound and sound, the 4-4 is sound and sound, the 4-5 is amalgam and sound root.
After the tooth status codes are assigned, the total number of tooth surfaces with amalgam fillings is recorded.
So we're going to count all of them. 1. And it's the surfaces, whether they're on the crown or the root. All right. 6, 7, 8, 9, 10.
Each of the 4 permanent upper and lower incisors is then assessed for presence or history of traumatic injury. If there is evidence of trauma, it's recorded as unrestored fracture, untreated damage, restored fracture, or lingual restoration.
The maxillary and mandibular incisors for signs of fracture or trauma that's caused pulpal death. And really he has no trauma to any of those incisors, so we would count them all as sound. Doesn't look like endo's been done on any of them. If there is a crown in the anterior, we need to ask if it was placed for aesthetic reasons or because the tooth was fractured. And so these are all sound, the ones that we have.
The final step in the oral exam is to assess the treatment needs of the participant. This is a subjective assessment by the examiner of the participant's needs on the day of the exam if there were no financial barriers.
We tend to use the very conservative assessment of treatment needs. If the patient is able to function well with the teeth that they have and their denture fits well, then we would not count that as treatment needs. In Mr. Gray's case, we just have one small restoration that needs to be done and probably his annual or semi-annual cleaning.
At the end of the exam, the participant is given a copy of a letter of findings to take to their next dental appointment. The letter indicates whether the participant should see their dentist immediately for urgent treatment, should see their dentist at their earliest convenience, or should continue their usual care. If there are urgent treatment needs, an urgent treatment needs form is filled out, and if the participant has given their consent, it is forwarded to the participant's dentist or physician. This concludes our demonstration of the TOHAP Oral Health Status Survey. We hope this encourages viewers to promote, support, and undertake the collection of oral health data. Some or all of the components that we've demonstrated in this video can be used to collect baseline and follow-up information. Together, oral health status and self-reported information are the most powerful tools we can use to describe the oral health needs of a population. We can use this information to design and evaluate programs to address oral health needs. We hope that you've enjoyed this demonstration, and we look forward to your feedback.